Good morning, everyone. Welcome to our monthly endovascular live case webcast in Mount Sinai. I'm Karthik Guja, your moderator today. Welcome from New York. We have Dr. Sharma here also joining us in a minute. And here we have another interesting case in the first case of our New Year's of 2023. Happy New Year to everybody. We have Dr. Kapoor, Dr. Krishnan's team, and we have another moderator uh, who's here specially to join us today is Dr. Srini Tumala. He's the director of the radiology at Miami Health in Miami. Good morning. Is Dr. Tumala here? Or, okay. Hi. Hi, Dr. Tumala. How are you? Thank you for joining us. And without any further delay, we'll go to the lab for Dr. Krishnan and his team. Good morning,
Yeah.
Dr. Krishnan. Good morning, Dr. Kapoor.
Good morning, guys. So we have an extremely challenging case. First of all, I'd like to wish everybody a happy new year. We're very excited. We've started a couple of new initiatives this year with our program, and one of them is going to be able to, for us to have a guest moderator and also to have one of our surgical colleagues in each one of our live cases. And we're really honored today to have a good friend of ours, Dr. Tumala from Miami, with his expertise in critical limb as well as in difficult cases such as this. And of course, we have a very good friend, Dr. Ajit Rao, who's been with us for many cases in the past to lend his opinion and also his thought process on how he would approach these kind of very difficult cases. So just want to introduce our team. To my left is our Ray Lascano, our nurse practitioner. To my right is Dr. Kapoor, Vishal Kapoor, who is the director of Mount Sinai Morningside and then cardiology for the endovascular side. To his right is Dr. Osman Jaffer. OJ is one of our endovascular fellows this year, along with Ibrahim. And then our nurses today are Mackie Mac, and we've got, which is Mark, and then we've also got Jen, and we've got Damien, who's back from vacation. So we've got a great team with us. So without further ado, so I can introduce the case, I'm going to ask Dr. Osman Jaffer to go ahead and present this case, which has a lot of challenges.
Yeah.
Osman, go ahead.
Yes. No, go in the slides.
Can you get the slides up, please?
Slides up, guys.
Yeah.
Hold on, give me 1020. Yep,
Yeah,
that's fine. Let's see what the
Great.
picture-
So, yeah, this is a very tough case. This is Mrs. R. She's a 73-year-old woman. She's a housekeeper. She has a history of CAD, type 2 diabetes, PAD. She had an aorto-bifemoral bypass in 2013 after unsuccessful right common iliac intervention. Left subclavian stenosis with a stent in 2019, which has since actually re-stenosed. We'll show that in a second here. Carotid artery stenosis. She had a TIA and then a left CEA in 2015. Hypertension, hyperlipidemia, ex-smoker. And she basically presented to us a little while back with bilateral lower extremity right greater than left claudication, walking about half a block. Unfortunately, she's just been extremely debilitated since then. Things have gotten worse. It's progressed to rest pain. She had a diagnostic study November 2022, and she was brought back today for intervention. At that point, we were going to bring her back the following week. She had to go out of town. And so she was sort of lost to follow-up for a little bit. Her meds are Clopidogrel, Bisoprolol, Atorvastatin, Zetia, Jardiance, and Metformin. And her exam, she's got a Doppler AT pulse on the right side. So ABIs are 0.4 bilaterally. Interestingly, when we bought her initially for our angiogram, which I'll show the pictures of, she's got the bypass graft. We got in there, got up, and had a very difficult time because of the bypass to get up and over. We thought about doing radial access for her. Unfortunately, her she has terrible radial pulses, no pulse on the left with a occluded left radial and a stenotic left subclavian stent. The right, the right subclavian also with a peak systolic velocity of 440 centimeters per second. This is her angiogram. So initially, we got access right below the bypass, got into the bypass. You can see patent aorto-bifemoral bypass. Right at the touchdown of the bypass over there on the prior, you can see there's a heavily calcified common femoral lesion on the right side. The SFA prox mid really looks okay. It's really the popliteal. You have multiple segments of short CTOs and really a one vessel runoff with an AT going all the way down to the foot over here. So, based on that, her symptoms have gotten to the point where she can't even work anymore. This lady's really debilitated, and this is kind of a last resort for her. We wanted to bring her back here and give it a shot to really try to get that popliteal open and maybe even work on that CFA if possible with possible Shockwave and DCB via pedal approach.
Well, thank you so much, Osman. I mean, I gotta tell you, this is one of those cases where we went through our thought process, and obviously, I'm glad that the two of you are here to help us. I think she's gotten so symptomatic because of her multi-level disease. I mean, she has SFA disease. She has a very minimal profunda, as you saw. She has no internal iliac, giving collaterals. She's got, we'll show you today's pictures, Vishal will go over it. She's got progression of the disease compared to the angio that you saw 4 months ago. She was on maximum medical therapy, as you saw that. And, this is a lady whose livelihood is truly affected. So the one would have been, okay, we'll have just some thought process from you guys on how you would have approached it. But I think the reason this is happening is because of the different levels of disease that she's having. And thank God she doesn't have an ulcer. And so that's why we decided to bring her in for this complex intervention. So Ajit, Srini, I mean, each one of you, how would you guys approach this lady? What are your thoughts on how you would do it?
I think this is a really tough case, like you said already. I mean, you've got a really acute angulation of that ABF, so getting up and over is very tough. I think if you can do imaging from above by, the arm, whether it's radial, brachial, etc., that's still going to be a challenge with the stents and some of the disease in the great vessels that you're dealing with. But I think if we can do imaging from above, and then you're just going to have to do pedal access like you guys are talking about already. Question is, do you access that, that single vessel runoff that I think I saw single vessel, or do you try to access one of the occluded diseased arteries that's really not a good runoff vessel so that larger sheath and so forth, especially if you're going to treat that CFA, you're going to need at least a 6 French sheath. So it's going to be.
Ajit, what do you think?
Yeah, I think this is a very challenging case, and I think it's interesting for multiple reasons. I think number one is just choosing the access site, right? Because there's so many different options here, and each has its pros and cons. But I agree with kind of a pedal approach here, because as we know, going up and over with an aorto-bifem is very, very challenging. It's just that acute angulation of the graft, and the last thing you want to do is disrupt your anastomosis at the proximal end too. So. We have steerable sheets and things like that, but it's still very challenging. So I agree with pedal access. And then as a surgeon, I guess the other things I always think about are surgery, but as we highlighted here, surgery is not a great option because she's already had that groin operated on. It's going to be extremely scarred in. It's going to be really hard to do an endarterectomy because sometimes you don't get that nice plane in a reoperative field. So I think an endovascular approach here is a good option.
Oh, you give hydraulic. Yeah. So Karthik, Raman, and actually before that, let Vishal go over the angio that we just took so you guys can see where we are.
Yeah, so we decided to go, with the complexity, no left radial, no ulnar, there's a high-grade stenosis at the left subclavian, so we really had restricted options to get the diagnostic pictures which Srini was talking about, the imaging. So we took an ultrasound guided access. The idea was here to keep the lumen size as low as possible, so we thought about doing just a 4 French access system to visualize our vessel. So we got an ultrasound guided access pretty much in the most proximal end of the SFA as much as we could. We did a roadmap just to confirm so we could wire into the bypass graft, which is what our goal was. And here you can see we did end up in the bypass graft. And then like how Usman had showed the pictures, you can see the aorto-iliac bypass all the way down. The bypass graft itself looks good, but as soon as just after the anastomosis, you see that very tight lesion, almost like total subtotal lesion, we'll call it, with a lot of calcifications, which you can see on a non-DSA picture. And then we, of course, wanted to do a runoff to define the anatomy well. And here you can see right at the common femoral where that very tight lesion is. The SFA proximal and mid looks decently well, just mild diffuse disease. But the real story starts essentially at the distal SFA popliteal segment, where you can see the vessel essential, like multi-level disease.
And this is where I think she's gotten worse because of this. It's definitely progressed and now it's really occluded at the level of the pop, or maybe underfilled. We don't know.
Yeah.
And then distal is one vessel runoff.
Correct.
So now, Srini, we interrogated the posterior tibial, very calcified, completely occluded. So we decided to go with just sheethless into the AT. So we've got just a 018 Trailblazer. We gave our nitro cocktail. This is our picture. It's a diseased AT, but not horrible. I mean, we can definitely deal with this. And you can see here that the PT is there, but very, very small. So one of the thoughts is, what about going up and over? I mean, Ajit, obviously you're the vascular surgeon. If we go up and over with say a Simmons 3 catheter, get enough nose, bury our wire in the distal SFA, track a steerable sheath up and over. I mean, what are the dangers to the graft for doing this? What can happen? I mean, is there things we need to worry about?
Well, yeah, no, those are all good points. Number one, it's just very technically challenging. I mean, maybe you have better luck than I do, but every time I've tried, my catheter just buckles out because of that acute angulation. I think steerable sheets have definitely helped us a lot with like cannulating viscerals and going up and over for these acute angulations, but it's still not ideal, and you could still, in theory, if you push, put too much force on the graft, you could disrupt your proximal anastomosis, which would be a huge aortic disruption and potentially life-threatening. So I don't think it's a great option if you have other choices.
So Srini, this I mean, you've done these cases. I know you wanted to go through the posterior tibial, which we could have. I guess we could have if we really wanted to try. Being this case, we thought we cross from below and then we'll deal with it. I'm not certain whether this is going to be a major issue in terms of putting a sheath in here. But obviously, we're going to do some cocktails through the side port of the sheath while we cross. But we're not going to put a sheath in until we actually physically cross this. So in terms of crossing, Karthik and Raman, what are you guys thinking? Your wires and stuff like that?
Well, before we go there, I just wanted to just the other option, which I don't think obviously we're going down a fetal approach first here. But Dr. Krishna and Dr. Rao, have you guys thought about also doing an antegrade option to treat the POP AT and then afterwards go for an endarterectomy of the CFA?
I think we
considering that there's a single vessel runoff, and if you have to put a 6 French sheath.
Ajit mentioned the groin is inoperable
for bypass,
for endarterectomy. He said he's scarred and
no, that's a good point, but it'd be challenging just because it's a reoperative field. So sometimes you don't get a nice plane when you go back into common femoral, and you can't really do an endarterectomy. And sometimes the tissue can be friable, and you might have to replace it with graft. So it's certainly an option if we couldn't do endo, or if we get a suboptimal result or something like that. But it's I think in a reoperative field, an endo approach is reasonable.
The other thing also, Raman, I think these are great points, and that's why we chose this case. I think the other point is, you could say, well, I'm going to fix the subclavian. Yeah. I'm going to come down through the arm. But then now you're talking about, she's not a very tall lady, but you're probably talking about suboptimal, peripheral equipment for this kind of case, right? So, the question is, I know the radial sheets are there, and you can technically reach. But the issue is going to be how is that going to work for you to be able to get all the way down and do your thing, right? Advance that a little bit, right? Yeah, there we go. Let's see.
I mean, if you don't have a problem putting a 5/6 slender into this AT, I think it's okay to go pedal, and I agree actually with Srini. I would have probably taken a posterior tibial axis.
This is a fielder.
Because even if you have to put a 6 French sheet to deal, the problem will be to deal with that CFA, right? What therapy? I know you want to do Shockwave, but again, you need a 6 French sheet to do Shockwave or any kind of atherectomy to deal with that CFA. You need a 6 French sheet. Now that's where the problem comes. The question is, should we go from the arm and put a 6 French sheet and deal with the CFA separately, and put a 4/5 like slender like lower sheet and DCB this area of popliteal and CFA, because now you have 018 DCBs.
So you have bilateral 50 to 99% subclavian.
Yeah, so it seems as though the subclavian would have to be dealt with independently.
Issue, yeah. So I think what you're doing is pretty much I think the only option left, I guess. So I think I would cross this again. I think we were talking about crossing. I would probably start with a hydrophilic wire and then I think clearly it's not going. I think you tried it. It's severely calcified. Then I would probably upgrade it to see if I can start with the Confianza or something.
Yeah, we're gonna switch to.
Yeah.
But definitely an 018, 014 wire. I would not try an 018 because I would probably not want to dissect this vessel. So.
Yeah, I think you're right. It might end up being a multi-stage procedure.
Yeah.
We might end up doing the distal segment first, which is usually not intuitive. They would want you to do the inflow, but
Agreed.
in this case, if we cross the CFA, but it looks the way it looks, I'm sure Ajit will tell you, like the calcification, the eccentricity, and the way it's cut off essentially at the CFA. It won't be that easy to cross over rather than having a chronic now.
Yeah, yeah, I agree.
The CFA segment.
Yeah, cross or treat. I mean, thankfully we have Shockwave now, so that I think has really helped with these calcified lesions. Because atherectomy, sometimes it's really hard to debulk this amount of calcium.
Ajit, the command is not going. Would you guys upgrade now to an 035 wire, or would you stick with a 018 different 018 wire?
I think I would try a couple times with like maybe a little, few different 014, 018 wires, but then I would have a lower threshold to upgrade because this just looks like
to me the way it's behaving, it's really
it's very
Srini, what do you think, buddy?
Big rock.
Yeah, no, I think if you've already tried a Fielder, a Command 18, you may have to, upgrade it.
I just need to now change out for a wire, a stronger wire to get the sheath in.
Oh,
this is 018, right?
Yeah, but there's a command.
018 command.
Is it? Which one is it?
014.
014. That's what I thought. Yeah.
So get us an
018
like command.
Original idea. It's too bad, we couldn't do an endarterectomy and kind of convert this to a hybrid approach, right? That would have been ideal.
That would have been an ideal situation. Yeah.
Well, the last thing you want, and Ajit and I spoke a lot about this, is an infection. And I think that this lady again, like I said, she's quite symptomatic, and I'm worried about the endarterectomy. I don't want any infection to occur. So I think that, I know it's worrisome. Believe me, we do very little pedal access. I think we've done one case last year with a sheath in the pedal, and that was a live case, or 2 years ago. Generally, now O&A command in here, generally we do not put sheaths in the leg. I mean, Ajit knows this, and we will if we have to in these kind of cases. So I think this is one of those where, I think we're going to be fine. I really do. I just think we're going to add a cocktail through the side port of the sheath. I'm going to upgrade here to a 5.6 slender. I'm going to put the Terumo Navicross in, cross it, and then I'm sorry.
I agree, PK. I think the 80 is pretty reasonable in size. I don't think a 5.6 slender is not going to make a big difference to that 80.
I mean, it may. I mean, it's always a worry, right? So
but
the 5.6 slender can be.
Yeah, it's a good size.
Can be placed on an 018 wire, so we're going with an 018 command here, right?
Yeah.
So good strength wire. So
just one point to keep in mind, about accessing this pedal vessel. Her left radial is occluded. So OJ, I'm sure you've reviewed her case quite thoroughly. I'm assuming at some point she's had left radial access that resulted in her left radial being occluded for some coronary intervention.
Yeah, they were all done outside. The coronaries were done outside, but I imagine so. That's probably why. Yeah.
So it is. So she definitely has some degree of
vascular
inability to tolerate distal access. It's not very often we see people who have just from a radial access for a coronary angiogram or any kind of procedure to have the vessel become occluded. So I think, this is not something that we would obviously advise for people to try on their first case as a single vessel runoff to access with the 5.6 slender. But this is when you've had the experience that Dr. Krishna and Dr. Kapoor and everybody has.
No, but I don't even think it's experience. I think it's the discussion, right? It would be bad if something where, cardiologist got this access or radiologist got this access, got into trouble, and then called the vascular surgeon to say, hey, can you please help us? I mean, the bottom line is, you want to be able to, have a discussion. If Ajit felt this was safe to do with an endarterectomy, we would have sent it. I mean, we've got a relationship like that here in Sinai where there's no issue with all that. We will send it. We will not worry about it because there's plenty of cases for everyone, and I don't think we ever fought over cases. So I think that this is just something where we feel it's safe. And I just think that this poor lady, is the main breadwinner from her family.
PK, question. We didn't cross across the graft, right? We didn't come across the graft with the catheter.
Like up and over?
Up and over?
No.
We
didn't. Okay. So are we able to fill the distal vessel at all, or?
Yeah, you saw the angiogram.
Right.
It was very poorly filled. Yeah. So I think right now we're just going to go with a Navi cross. We need to cross this. Yeah. Oh no. 035.
I'm saying just to define it better, like what's happening in that area, like how is the occlusion behaving? So just so that we can have a roadmap.
Which occlusion are you talking
No,
about?
I'm talking about the POP and the distal SFA.
Yeah,
Well, we have picture. Let me show you.
We have a picture.
We have a few pictures right here.
Yeah.
Hold on.
So let me cross this, you know, with everybody's help, and then we'll talk about how we're going to treat it. So now we have a what is it called? 00556 slender in. We're going to add a nitro drip to the sheath, Ray. Nitro drip to the sheath, just to keep it there. And then what we're going to do is cross from below, and God willing, you know, everything goes smooth. So Ray's gonna hook up the nitro drip while me and Vishal just advance this up through this. No resistance, no nothing, going super smooth. That's the collateral. That's the reconstitution of the vessel. Now we're just gonna try to work with this, Vishal.
Yeah.
Let me try to do a little blunt dissection here with this.
No.
So I think the other important thing is, you know, what you're treating. You know, here we're mainly treating like claudication, right?
Yeah.
So like she has multi-level disease, which is kind of surprising. She's not worse off, but you could make the argument too if you're having trouble to just treat one level.
Let's get a note.
This is a little different because normally you treat, you know, proximal to distal, but another option is just to treat one segment if you know we can't treat everything.
But Ajit, does it make sense to treat just the POP? Because to me, if your common femoral inflow is bad, you don't have a internal iliac filling the profunda, right?
Correct.
So now you've got complete cutoff with the common femoral and the profunda, and now you fix the outflow. I mean, do you think that would really help? At least
no. I mean, in this case, it doesn't. We can't do that. But in general, you know, when you're going antegrade or in the direction of flow, then potentially you could just treat one level, like the common femoral, and then see how she does.
Ajit, just a question. Let's say, hypothetically, I mean, we're going to cross this. You've done it before.
Oh, we don't know.
I'm just saying, like,
I'm glad you
hypothetically.
have such confidence.
I mean, I'm
saying
Kamala here. Come on.
Yeah, no. I mean, it's PK doing the case. It's PK doing the case. I'm pretty sure we can cross it. But I'm saying, hypothetically, if we don't cross it, and if we have to pursue a surgical option, would you do an endarterectomy or a hybrid, or just directly go for a fempop bypass?
So I think I would try to do an endarterectomy. You know, if we can't do an endo, I would try, but I would go in, you know, having a high suspicion that I might not be able to do get a good plane and remove all the plaque, and either would have to remove that segment of the artery and do like an interposition graft. And then I think I would probably stage it, to be honest. I would probably just fix the common femoral and then see how she does after that, rather than...
But if you know that she's so calcified in the POP and occluded twice, why wouldn't you just consider an option of doing just a bypass for her? Fempop bypass.
You mean going above that plaque and going into the bypass?
Yeah, just do a common femoral to POP bypass.
Yeah, I mean, I think the other consideration is whether she has vein. You know, and especially with her multi-level disease, I would rather save her vein, you know, and use it for like critical limb if she progresses. So I would probably just try to fix the inflow first and save her vein, to be honest, especially for claudication. But yeah, I think that's a good point in other cases. I mean, that's definitely an option. You know, just go straight to bypass.
I mean, especially if she's so calcified and everything, I don't know how much the endovascular option will stay open for her. And this is going to be the same difficulty next time you operate on her, right? It's not like the difficulty is going to be any less.
Correct.
And every time we access her, you have to access her pedal vessels. A bypass as a long term might be a better option for her.
Lose the loop?
Reduce.
Yeah, I agree. I mean, you know, I don't want to mention the best CLI trial and start a whole discussion on that.
Yeah,
but
no,
I mean,
I'm not talking
my
about the
point
best CLI
is,
trial. I'm just saying, like, this is a unique case, right? It's not like a common. You don't see these kind of cases commonly in your practice. So.
Yeah, no, for sure. It's definitely a good option, but especially if she has vein, I think I would consider that.
I think the other thing that we've done, you know, a lot of these patients is we've staged them as well.
What do we have for
Raman said, you know, I've punctured patients like this their distal disease first.
Open-8 command.
And then came back a different day to kind of tackle that CFA disease and when they're not operative or not ideal surgical candidates, right? Because then you have options where you can puncture different things.
Give like 200 bullets.
So, Srini, if by any chance PK gets into he's in a plane, if he doesn't re-enter in the vessel, would you use a re-entry device from below?
Stefano, go ahead.
Well, I mean, at this point, he's got a 6 front sheath, right?
Yeah.
Doesn't he have a
Yeah.
Yeah, it's Farixga under.
Yeah.
So I think, you
Yeah,
can.
we
We've
had
done.
I mean, I have never used it. I'm pretty sure PK has not used it, and Vishal, and none of us in Sinai use a re-entry device from the foot. But have you had experience with it, or?
I've done
mean-
it. I don't like
I'm-
it, but yeah.
Well, I don't think it's a difference. I mean, what's the difference, right? It's
right?
whether you're
Gotta
from
shoot.
above or below, it's just going to work. On
No,
one
it's
way or
just
the
a
other.
bulky device going through a pedal vessel. That's why I'm asking.
Get an
It's
overlay
like a-
Terumo wire. Overlay Terumo
Yeah, I
wire.
think
guys.
the
Which wire is this right now?
He's just trying with a command. I'm going to
Command.
try with the Terumo.
Yeah.
Get a feel.
Yeah, it's
So-
in the plane.
It's interesting that
Okay.
so far, PK, you haven't
back.
used a Confianza or any other CTO crossing wire yet.
Nah, we're just trying to just pop in, see if it goes here. Let's see. Nah, that's in the vein, looks like. Well, maybe not. I don't know. Let me see.
No.
Let's do another roadmap. She did move quite a bit.
Proximal DVA could be interesting.
I don't want to hear that word DVA area.
Yeah, that's
like,
like way outside of.
hmm So we're outside the calcium there, so we're
Yeah.
going to pull this back.
Yeah.
And then we're going to try
Probably
to
in
go
the
with-
vein, you know.
Try to go with another wire here. Track my catheter up.
Yeah.
Yes. Oh,
If you recall, maybe 2 or 3 months ago, we had our live case again with a popliteal CTO.
Wednesday.
Very challenging. We had to frog leg because of a
All right, get a
plate
Confianza as well.
in the knee.
Here we go.
And eventually decided to switch from the antegrade to the retrograde approach from the pedal. And remember, just the distal cap is usually so morphologically distinct from the proximal. So all that challenge we had crossing proximally was kind of abated by just going from the retrograde approach. But over here in this case, which we guess you don't see too often, is that this distal cap is so densely calcified.
Mhm.
You know, so
Yeah, I
it's-
mean,
the actual luxury that we typically have, we don't have today.
I'm just going to try to do a dissection reentry here. If not, like
Yeah.
that Dr. Tamala said, we're just going to go with a this reentry device and just pop in. I just want to make sure whether we were able to get.
Yeah, you
close
formed
here.
a plane onto the onto
give me a
that side.
torque,
So
I guess.
that's why.
Yeah, but that's what happens, right? With the 035
Yeah.
system, it just
Parker.
becomes harder.
Yeah, yeah,
I mean, planes are there, but what do you know?
yeah, yeah.
The old adage is either you poop or you get off the pot, right? So the bottom line is where
Do you rehearse yourself in the morning? PK,
No, but
before you
honestly,
come
I
to
mean,
the live case?
Ajit and I spoke about it. We're already on
Or
the
you just
pot.
come
We
up
might
with
as
this
well
kind
go.
of stuff.
Well, we're committed.
Yeah, we're committed.
You guys
now.
were
We
talking
gotta
about
get through.
your bathroom etiquette in the morning.
Yeah,
before the
exactly,
case.
I don't like where this
early morning
conversation's going.
exchange of thoughts.
No, but I mean, it's
Where do you think we get all this?
Srini, don't worry. This is how our live cases are normally. So I know this is your first time.
At the end of the treatment algorithm, that was the final conclusion.
Yeah.
That's
end
where we
of the
get all
flow
our text
chart.
messages from in the
Yeah.
morning.
So at this point, would we use a
there it
kind
is.
of more of a CTO wire? PK.
Let's see,
Would
you're
you use
still
a-
outside.
We are still on the plane.
yeah.
yeah.
I think we're gonna go with the CTO wire now. I'm just, with this wire, it's pretty good in the sense it'll try to
It's
find
actually
these planes.
a spiral
So
around, yeah.
it doesn't look like it's gonna go. The loop is quite large.
Would you
And
try a 035 system before using a reentry device, or just go straight to reentry?
You
here?
want to go with a Terumo glide wire because we're already dissecting. That's what I'm
Yeah.
thinking. Or you want to go with a
Because
straight
you're already
Terumo?
subintimal at this point, right?
Right.
it-
Yeah.
I think we'll try a CTO Confianza,
Confianza.
and then if not, then we'll go with a re-entry device. We can try the. Do we have the NTR, Damien?
I don't think I know.
I thought we had 1 or 2 NTRs sitting around for these kind of cases.
And I guess the
I
other
don't think we carry that in the lab
No, we don't
anymore.
anymore.
No,
No.
No.
oh no, just when you needed it, right?
I think just pull back a little bit more.
And then would you try? Would you pre-dilate if you're going to use like an outback to help it track, or
I think
with
you
this amount
have
of
to, right?
calcium?
We have to,
yeah,
no?
yeah. I
Especially
don't
with
think
that eccentricity we took right at the proximal pop, the P1 segment.
Yeah.
That eccentricity, I don't think our outback is going to go through that bend.
I don't know. I mean, the Navicar kind of popped in quite seamlessly.
Right.
I mean, yes, it's a hydrophilic catheter and all, but I think the
that's what-
plane we created was sufficient enough.
Yeah, that's what
No,
PK
for
did,
the
is just
outback.
try to bury the Navicross in so that we could
Yeah.
find a nub and hopefully just push it through.
This looks a little better.
Looks
It
here.
better.
looks like a different plane. Yeah.
Yeah.
I mean, you're just getting close.
Same plane as you get.
No, we was pointing in the correct direction to begin with. But again, you're right.
So Srini, once we cross, which we will,
Very confident.
I am that's my confidence on you, PK. That's fine.
Oh my God, more pressure.
Yeah, no.
So, so Srini, what would you do? That eccentricity, that big calcium chunk we just crossed in the P1 segment.
Right. What's
What
going on?
would you? How would you treat that? I mean, I don't think Shockwave can fix that bend, right? So
I think on top of it.
I think Shockwave is still a good option, though. Karthik, as you know, it works well even if you're subintimal and you get some level of calcium disruption.
Right
you could try a sculpting balloon, one of the sculpting balloons, right, to try to crack or break up some of that calcium. That's another option versus just straight angioplasty. I mean, at the end of the day, this is going to have to be a stent, I think, right?
Yeah, definitely. Yeah. The question is, can we expand the stent through that segment? That's the.
I think yeah, it's got to be a supera, right? If you're going to go stent.
You have to use a supera.
Pull back. Let's go to the bottom line. Start here again.
I'd also have just covered stents available.
We'd look
You
for
know,
that.
this amount of calcium and disruption and
Definitely agree,
dissection.
I mean, you've used Shockwave when you've been subintimal, right? Even though
Yeah. But it's just the P1 segment. The bend it took is just.
I mean, we all know that the Shockwave works better for more concentric calcium. Obviously, better if it's truly luminal. But I think in this case, you have a difficult access.
Yeah, I think it's stuck, right?
Complex multi-level disease, single vessel runoff.
All the way up. There you go.
I think at this particular point, the fact that she's does not have chronic kidney disease is like surprising, but like that's the typical extra complication. But like, you know, I think this is over here. We just try to achieve the best we can without causing too much harm. I think Shockwave again is going to be the only real debulking strategy. You know,
give me a 018. What is it called?
Pull it back, do an Astaro.
This one. No, Astaro. Let's try the 018 Connect 250T.
PK, any hesitation, any reason why you're hesitating to use just a re-entry device just to
well,
quickly cross
we have time. I mean, I think what I'm going to do is I'm just going to try once or twice with two different wires, like the way Srini and Ajit suggested. And then Srini, Ajit's already suggesting to go with a 035. Can you just give me an 035 glide then while you look for the Connect 250T? And then we're just going to go ahead and do it. 035 glide, please. So that's why I'm just going to try to, I don't want to lose that collateral and get subintimal in that area, but I think at this stage, like what we said, we're already on process here. Nothing much we can do. 035
we're on the pot,
Connect
as you say.
250T. Yeah, we're there. I mean, we already got pedal access. The fact that she's not ischemic right now, she's not complaining of foot pain, makes me feel better. I keep asking Ray how she's feeling, and Ray says she's sleeping. So that's a good sign. Put a torque around this guy.
Yeah.
And I think that's a good one. I mean, I think, like Raman said, that distal calcium really screwed us up here.
5 torque. It deflects you off from the lumen.
Dedication to your own adage as always. Just start over.
Calcium is the enemy, right?
Yeah.
Right.
But I also like this approach of like upgrading, starting with 014, 018, and then, using an 035 as kind of a backup. So that way you don't really propagate that or like open up that dissection plane, and you have a higher chance of trying to find a new plane. I think that's also smart.
Yeah, we've tried that multiple times here. I've come back multiple times. It just seems to be getting back in that. We could pull back all the way distal and try again with another plane.
Yeah.
Always
start again from the very beginning.
Yeah.
Maybe just go all the way back to that calcium.
It looks like it's in a vein.
I don't know. I don't know.
That looks pretty good.
I don't know. It's starting to move better.
I think
No, it's still in the dissection
outside.
How can it be moving that freely, right? Who knows? I am more talented than I feel I am. No, I'm joking. Yeah, I went out in the right spot.
We're right on top of it. You can see just going all the way.
The other thing we can do is torque this and try another plane here.
That would probably pull back more.
Let's try that plane here. Let's see where it goes. No, it's definitely not good.
There. Different.
Nope, got outside the vessel again.
But it's heading.
Nah, I don't think it's in the right spot.
Looping around,
I don't know.
Yeah, that's how your 018 made the loop. That's how your 018 made the loop.
Right.
All the way over, yeah.
But it's going in a different
Oh,
plane.
that's a collateral.
That's good.
Yeah, that's a collateral. So give me now an 014 wire.
Just a vein.
No, I think it's a collateral.
No, it's too out of the way.
Ah,
This
it's
is
too low.
0.4.
Okay.
So
I
PK,
probably pull
Karthik,
back.
so we started with a fielder guide wire, then we went to a Command 18, then a Confianza. Now we're trying a glide, 035 glide.
Right.
Connect to. So
No, you're
glide.
trying a 035 glide.
Glide. Okay.
This is 0.8.
Now I will say I actually have not had too much luck
helicopter thing.
going from like a hydrophilic 014, 018 to a Confianza and then going to an 035.
All right, give me the Connect 250.
Traditionally, if I go downwards, go with the 035s, then to maybe a hydrophilic or CTO wire 014 system. But I have, especially from the retrograde approach, I also have, I believe, very, very rarely put a sheath in the foot. But I've not had as much success going from a smaller caliber wire to an 035 system. Because I think it's just the same problem that we see, as you create these big loops and big dissection planes, these other wires tend to kind of,
So, how do you upgrade
That's
your wires?
confidence in there.
From retrograde, do you directly go with 035s or do you start with 018s or how do you do it?
Get us another two of
Yeah,
018, please.
Go on 018.
Yeah, I usually
Another
start
Connect 250. Yeah, it's gone.
with a fielder. I like fielder. I think that's a
Okay.
great take
Stretch.
guide wire that tends to find micro
I'm
channels. So
gonna
I
pull
usually
back a little bit more.
I quickly escalate, Karthik, like you said, from 014 to usually from there I go to a Command 18. Command 18 doesn't work. Confianza, that doesn't work. I may go to a heavier wire like a Connect 250T or one of the Estados.
Get us a Command 18 as well. Don't open it.
Okay.
Eventually, I'll get to a glide wire. A lot of times, I like a straight glide wire, because I've already got a catheter, and sometimes that helps me in
Interesting.
using my
Huh?
escalation.
It's fine.
So we're just now. I pulled the catheter back.
So,
I'm going to get
you
the outback ready.
You usually tend to access the occluded vessels in the pedals as much as possible.
So again, in this one, if it's like PK was saying, it's a very heavily calcified posterior tibial artery that's occluded. That's going to be very hard to cross, right?
Right.
So then you're kind of battling that vessel to cross. I think if it's relatively non or minimally calcified, then it's easier to, do the so-called Schmidt technique where you access an occluded tibial and use that as your conduit for therapy above. But in somebody that's pretty heavily calcified like she is, you're basically, the likelihood of crossing that PT is going to be tough just from below. And so in that case, I would have accessed this anterior tibial. I would have put a sheath in, run the drip, whether it's a combination of heparin, Rapamil,
Right.
whatever your skill is. And then I'd fix like what PK and you guys are doing right now. I think the only other possibility here would have been, although not ideal, is an antegrade proximal SFA stick, fix the SFA, fix the pop, see what the outflow tibial looks like, fix that. Well, you don't want to fix it because it's not a CLI patient. Leave it alone if you've got inline flow, and then come back a different day to tackle the CFA from a different. That's another possibility, right? It's not ideal, but that's another possibility.
Agreed.
Yeah, we have
a great
plans. We
approach.
might be able to.
Well, yeah, I think we're getting ready for our outback here.
Yeah.
I'm just trying a few things while we get the outback ready. I think we're going to have to make a balloon angioplasty of this segment and then take it from there. See, that calcium just keeps pushing me out, and that's going to be the problem.
And which wire is this right now?
This is the Connect 250T,
And
which
we're
I
through.
think crossed.
Yeah.
Yeah, it just crossed as we open
As
the
the
outback.
outback is open.
As we open the outback. All right, now, crack. Yeah.
See, PK, what did I say?
You just have
we're
to
off the
threaten
mark.
it.
I mean, go ahead.
It's like I have more confidence on you than you have on yourself.
Oh,
There,
there you go.
I'm just trying to screw
Always.
it
That's why. I mean, Ajit was telling me back here, we can do it, man. Hang in there.
in. We
We have to root for one another, guys. This is not easy. We all know that.
Yeah.
Let me tell you, every time
let's
people
make sure.
under pressure, somehow he
Push the wire
seems
a
to
little bit
cross.
more.
You know what?
Yeah, I know, right?
There you go.
No, you just have to
All
push
the way
it.
up to the wire.
There it is.
Yeah, you're definitely in. Okay. All right, let's take a picture
Yeah,
here.
it's definitely in.
I hope.
Yeah, you're in. It's like 2-3.
just as Vishal and I are laughing. It's all our fault.
Contrast right there.
Do we have blood flow? I assume we have blood flow at this point.
we're just gonna
I'm
Yeah,
hoping.
he is. Yes. I can see it dripping out of that overnight.
No, it's an 035. That's why I'm scared. Oh, yeah. Oh, boy.
There it is.
This is what happens.
Really?
Unless the plane is
give us
really
a-
big.
It might be a really big plane. Okay, give us a Commando 1A now. So we're already, yeah, I'm glad you opened the Outback, so we can do the Outback if we need to. Let me just try with the command, we'll know where we are. This is the old one, right?
Yeah, because the 035 did make a big plane, so it could have been the plane, but
No, but either
it's
way,
fine.
this is an area we're going to have
Yeah,
to get through anyway.
re-enter anyways. Yeah, agreed. Would you re-enter it right below the level of the collateral, Srini, Ajit? Would you guys do it below the level of the collateral or above the collateral?
I mean, what do we on top of it?
I personally would try below the collateral if I can, and then work my way.
Preserve it.
Yeah,
Yeah,
because
and
you
work
have a
my way up.
segment below the collateral where you can re-enter, right? So
It looked
Right.
like
I think
we
it's
were
always
in there.
safer
I think you
to
just have
try in
something
the
to go through.
unhealthy
It's gonna
occluded
happen
part
that way.
first, and then work your way to the healthier vessel where it
Agreed.
reconstitutes, so that way you
Agreed.
don't burn bridges.
agree.
Not always possible,
So,
but yeah.
PK, it seemed as though from the 035 catheter you did not get any blood back.
We did not, brother.
Oh, yeah.
Yeah, and you can see
Yeah,
we're on the
it's-
side.
All right.
Okay, we'll put it back. I mean, there. Just.
We're in a plane. All right, let's get the Outback ready.
Yeah.
It's another plane.
It's the dissections in the
Yep.
the
Let's
2D
leave it
image
here.
of the 3D
All right, give me an
dissection.
014
Yeah.
catheter now. Give me an 014 wire so we can take
I have
this
it.
extra stiff,
Okay, color.
what is it called? Extra stiff command wire.
Do you want me to
Okay,
put
so you're going to use a photo balloon to create your track, or?
I don't know. This
I
thing went
think
pretty
if
smooth.
this went through, exactly. If this
So
went
I'm
through,
going to try it
hopefully-
once without
I mean, it's
making
Navicross, but
Let's
Outback
see.
is very bulky, so I don't know if you'll make that bend at that popliteal. That's my concern.
Yeah.
I think we
I
should
think
be
it's
able
worth
to do it.
trying,
Straight
just so
in
that
line.
way you don't
Just
push
try
the
it, yeah.
dissection out further,
Yeah, that's what I'm trying to do. So, and then it becomes harder to use the Outback to go. So I'm just going to go ahead and I have a command extra support here, 014.
018.
We're going to get the Outback.
I'm sure Karthik you've seen or Srini as well. Like once you have a lot of dissection plane, the hematoma actually pushes onto the true lumen. It can collapse it. Now it becomes even harder to go with the re-entry.
Correct. Yeah, and it makes a
Because
bigger,
It becomes-
false
yeah,
lumen to
exactly.
which makes
So
it
you
harder
don't want
to
to
re-enter.
compromise your true lumen to a point that now you really have no lumen to enter into with your wire. So
Okay, let it sit there. That's
Yeah.
a good spot. And
The question is, where are you going to re-enter here? Are you going to go as high up as the wire, or are you going to go try to start back down?
I'm just going to, we could take a picture. We know the reconstitutions are on 20, right? So
Yeah.
I think, is that right, brother? 20
Yeah.
around 20? Right? So let's go around 20. So raise flush the Outback. And this is the nice part of, we could use a Pioneer, but it's a little more bulky. So we're going to go with the Outback.
Pioneer is way bulky.
Give me a wet one, guys. And we're going to go up here.
This is our first pedal reentry case, PK.
Well, it would have been nice, like I said, if we had that other anterior catheter. But I think here we got, this is a nice decision-making case where we have I'm just going to go real smooth here. Let's see
Yeah.
how it goes without having a little resistance somewhere.
Yeah.
Yeah.
Poorly.
Right out of the sheath.
Right at the
bro,
bend.
yeah.
Yeah, this is what we were a little worried about here. Yeah, it looks like there's a stenosis there. Yeah. There's going to be
You have to balloon your way up. It's
All right,
not.
walk it
Yeah.
out. Get us a 3.0 balloon. 3.0 balloon.
Proximal AT though, right? We get a
Yeah,
good look at that.
proximal AT again at the proximal pop. It's Outback. Outback is bulkier than it looks. So
Yeah.
Oh, no question.
yeah, especially the bends. When it goes through the bends, like even aortic,
Even
like
up and
bifurcation
over,
bends,
yeah.
it has difficulty. So there's no way it's going to make these bends. So
The only question is, we can't straighten out that bend by doing any sort of maneuver.
no,
3.0
just
balloon,
I
guys.
think it's more of a lesion than here. I think.
Yeah, there's calcification right there
Yeah.
as well. You can see, of course, not as dense, but definitely there. Flush it.
All right, so we're gonna go. So, any thoughts if we fail with the Outback? See, the Outback
I mean,
doesn't go.
one way to do it is
Pull it all the way
take
back and restart.
take an antigrade access with a micropuncture access kit, create your track, balloon it, and do a cart technique.
Well,
At that point, you just cross centigrade.
Yeah, I mean, if you
Yeah.
cross, you cross. But I mean, the question is, you don't want to put another sheet because now you're again staging the process, right? As Srini wanted to do from beginning.
Yeah,
but
there's a
if you
tight
can just
lesion
do it,
there.
if you can cross it with a micropuncture access, take it out, balloon it, do a shockwave in the common femoral, finish the case off today. It's off.
Oh, good day, you know.
Well, like I said, I think that's where we'll have a discussion. But
Yeah.
let me at least balloon this, and then once we cross, see, yeah, there's the lesion. Look at that. Look how tight that was. That's tight right there. Yep, by the ostium. What it's 14.
Because if you come from above, even with the pedal axis, even with the micropuncture axis, you can use a coronary balloon to go through a micropuncture
Just go
axis
up here.
and use a 5-O balloon.
I think we
coronary
just,
balloon
yeah,
and
balloon
then
it all
I
the
think
way
it's
up.
balloon now.
All the
We're
way up,
already
yeah,
here.
exactly.
Balloon
Create
this.
a card technique,
I would just balloon the whole thing with this 3O. So at
Okay,
least,
let's do a shot from above.
Look at that.
Yeah, that's what my
say it deflects
Look
the
at that.
calcium.
see. That's my concern right there. The deflection, eccentricity.
Man, at that point, that much, being outside the actual vessel, the other question is, do you just go straight for a covered stent? Because even
Well,
yours
let's
is
see.
No,
there.
I think I think if you can expand, Supera will be fine. I think.
Quite
I think
outside.
one of the only drawback, Raman, I would say,
Go up here.
of stent is that, a single vessel
Yeah,
runoff, right? You're
yeah,
out.
yeah, yeah. And
Yeah,
also
you're
covered
from-
stent through the pedal. It's bulkier. I don't know if you'll
Yeah.
it'll strip off, and then now you're. I don't know. It's not a
And
fun
if we
thing
look
to.
Yeah, and if
Yeah.
we look at the covered stent, this is a long CTO too, so it's not, the patency rate, right? Primary patency rate of the Viabond in this case. I would
PK, any
say.
reason you pulled back or?
I just wanted to get a feel, but sometimes a wire can
Okay.
pop in.
Yeah, well,
know.
this is this like a technique like ballooning when you know you're interluminal to try to open up that true lumen, so that way you get kind of push that dissection flap back down?
That's what I'm trying to do,
Is that-
exactly.
yeah.
But I mean, it can, sometimes you'll get lucky, right?
Yeah.
I just,
Tears open
we're
to
just
the
trying to
bone.
see whether we get lucky.
We do frequently get lucky here in this lab, so.
All right, I think that's good enough. All right, walk it out.
But I like Karthik's idea of like just doing a micropuncture from above and trying to
Yeah.
meet in the middle somewhere. It may not work because this cap is so like calcified.
Yeah.
So even crossing, antegrade would be.
We can try getting the outback, but I'm very sure outback is going to have
I think that's okay, right?
pretty significant difficulty
for a
getting
while.
across
Further
that band.
Yeah, what?
Okay,
Yeah.
let go of the
So it's much easier to just balloon it and do a card technique, but we can try outback. We opened it anyway, so we might as well just try it. That's a good place to re-enter, PK, right
Yeah,
below
right
the
there,
level
about
of that
21.
cap.
Yeah.
Visible,
Pull the wire
balloon
back.
is not pull the wire.
Let me just push this up. Hold on, let me just try to see. Pull the wire completely back.
Okay, sure.
You probably need to be past the cap a little bit, right? Because otherwise it's just going to get stuck
Yeah.
at the calcium.
Right, right,
Push
right.
the wire now.
The wire has to be definitely
There you
past
go.
that.
That's
balloon.
perfect. Now walk
That's
it back.
fine.
Oh, that's a good, yeah.
Yeah, we just wanted to get the wire in a nice spot before we try once more with the outback. Okay, let's go.
All right, step 1, AT
Outback
hopefully
right there.
crosses.
Yeah,
You guys still have the infusion running through the sheath of the nitro and all?
Yep.
Yeah.
PK, question, in your experience, Srini and Ajit and Vishal, anybody, of course, you, Raman, what you guys think Pioneer is much more bulkier than Outback in general?
Yeah. Yeah,
Like to go through the bends. I'm not talking about the size of the. I feel like Pioneer actually makes bends much easier than Outback does.
Well, we could try the Pioneer. We have that too.
Yeah.
No, I think
Srini and Ajit, what do you guys think?
Okay.
Srini, what do you think?
Let me see.
I haven't noticed, to be honest with you. I think they're both a little bit bulky around the turn. I don't have enough experience with Pioneer to tell you, Karthik.
Okay. Because I don't use Pioneer that much either, so.
Yeah.
Nope, not gonna go.
I think the only difference is, isn't the Pioneer tapered a little bit more at the?
Yeah,
distal tip?
that's why I thought. I mean, normally it's
All right, let's
a
get
small.
a Pioneer. Let's see.
It's a bigger device, but it just makes through the bends much easier because it's tapered at the end. That's what I thought.
But let's try. I mean, listen.
I
I'm
know
willing
PK
to-
has the most experience of all for
No,
Pioneer.
I've never done through the Outback. I mean, I've never done Outback from the foot,
Pioneer
so
from
I'm
the foot,
obviously
yeah.
learning. The only question here now is whether we quickly stick antigrade, put a wire down,
Yeah.
and come from
I
above.
think we
and
should at
try to
least get
cross.
ready with an ultrasound to stick antigrade.
Yeah.
So I think
So we
prep
got-
the
yeah.
antigrade access.
Well, it's all prepped. Everything is
Oh, okay.
prepped.
Where would you stick the
Yeah.
I just
SFA?
stick the SFA.
Yeah.
with-
Yeah,
with a-
SFA,
with a
just
wire.
micropuncture. Yeah.
And just put a wire down and then track it down, and then we can either re-enter at the pop and work from below.
Yeah.
just put a pedal access kit. I mean, a pedal access catheter there, which is 2.4
like
French.
a cook sheet. Yeah.
Yeah, cook sheet. And then use a coronary balloon and dilate it.
Well, I don't know if a cook sheet will be long enough to reach, guys. You got to flush it.
Yeah.
No, but you can take no, PK, when you put the wire down, cook sheet is 2.4. It'll take any coronary balloon through it. Just go and balloon it. And then after that, you can take an 018 or an 014 wire and just cross.
No, I'm not saying no. I'm just saying that it's going to be interesting to see the length of the sheath.
Yeah.
I mean, the
Question is the advantage by doing a cook sheet is when you go from below, you can do the intervention from below. And once you can take the cook sheet out when you're doing a shockwave there. So that way the access site is sealed. You don't have to worry about
a thin lady, so I think
it should not be that difficult. Like the hematoma chances are also much less.
Well, if we cross, we can always either balloon tamponade it or something.
Yeah, that's what it is. That's what I'm saying.
So
if it's 2.4,
nothing. Don't rail it.
Fingers crossed. Fingers crossed.
Fingers crossed.
I knew this would be an interesting case, but not for these reasons.
Is this wire stiff wire? Is this a stiff?
It's a stiff wire.
It's extra stiff.
Yeah, command.
Yeah, I feel like this is probably has less trackability than the Alpha.
Yeah, I agree.
There it goes.
Oh, stand corrected.
No, I'm telling you, Ajit, I feel like this has more tapered flow than anything else. Outback just is a smaller device, but it's this is more tapered. To cross through the bends,
end
this
of
is
it,
much
you mean?
easy. Yeah. It makes the bends much easily. But it's just calcium is the problem for this device. It's like if you have too much calcification, you have to make a bigger lumen for this device.
Yeah, it's a bulkier device. You're right. With
Much
the taper
bulkier device.
But definitely much more bulkier. And that way outbuck delivers better. But again, you're right. That it's stiff. That's why I guess
The
it delivers
question is,
better.
should we poke a hole and try with another wire through the other hole and see where it goes? Let's try that.
Maybe find another plane.
Yeah, let's just find another plane. All right, give me another command.
No, but you can't take the.
You
wire.
can't. You have to take the wire out.
This is not outback.
No, you can. It goes to it goes to the back, guys.
Is it getting stuck in the occluded segment, or is this?
Yeah.
No, in the calcium, not making the calcific bend.
So your plan now is to take the second axis, like the second port, and just try to wire again
Yeah,
approximately.
so bare back
Brand
end.
new
Yeah,
port.
exactly. Take
And
the
just
wire.
Try
This
to
wire.
get the needle and try to do something here.
Is the chromoflow on?
I can't even see the needle. Give me a
Can you
wire.
get the chromoflow on?
Give me the wire, please. Command. Yeah, I need just 014.
Like an anterior catheter now.
Yeah, well, we're way low. I'm just trying to see whether we get another plane, get another loop, and take it up.
No, the best thing is you can see, if you're in the occluded segment, see where the normal vessel is and just try to poke into the normal vessel. It
But
might be
there is
through
no
the-
normal vessel here, right? It doesn't fill. It's completely occluded.
I know. But
All right, let's see here. All right, Ray, why don't you prep the antigrade here?
oh, you can turn on the chromoflow off. That's fine.
Because
yeah.
we balloon down here too, right?
Correct.
With a 3-0.
Just 3-0, right?
Oh, just the three.
If you use like a 4-0 or something, then yes, I think it will pass through.
Same problem.
You want to fire your needle? A little
I
bit?
did.
Wow.
Oh, you did? Oh, okay. I didn't see that. Oh, yeah. So maybe we'll just turn directions and try to see if we can.
Hold on, let me turn the direction here.
Exactly.
Nope, the other direction. Let's try there.
Yeah. Just like.
There's the needle right there.
This might give you a better plane. Who knows?
Yeah, that's what I'm saying. It's just firing.
That's what I'm just trying. I'm
Yeah.
trying something different here.
Because that looks like it's outside.
Well, I know, Karthik. I'm just trying to get a different plane, brother.
I know, but
That's way outside.
Yeah. The other thing you can do is just try to slowly pull back the needle, right? Like not fully release it, and see if you poke right into the right plane.
Push it up now.
Yeah, that's what I'm trying to do.
What do you guys see? Could we pull up the IVUS?
Yeah.
See what we're seeing on the IVUS?
You see nothing on the IVUS. Oh, let me see
Nothing
where
at
this
all.
one goes. Nope, that's out. Let me pull back the needle a little bit. All right, let's get antigrade access, guys. We're effing around too much.
Yeah. You know, and sometimes in thin people, you know, you can
It's a
put an
rock.
ultrasound on the side too and see where your guide wire is from below.
Yeah, you could do an EUS and then
And see if you can
try
see
to
the lumen
yeah,
and try to re-enter that.
that's a
That's the calcium.
But antigrade access would probably be the most useful. Plus, your imaging will be improved tremendously, right?
Light.
Yeah.
Yeah, exactly. Yeah.
Nothing is going to break.
Nothing is going to break this.
Yeah.
Tough rock there.
Wow. All right, let's walk it out. Hold on, let me lock this.
Yeah. Make sure the needles are back.
Yep, needles are back.
Okay, let's go. You may have to give me a
You see
regular
the whole thing
ultrasound.
moving with that now.
Yeah. All right. So, all right, let's get the antigrade. Ajit, you want to do that, brother?
Yeah,
The
sure.
antigrade
Come.
stick.
Uh-huh.
Give me. I'm going to continue to work from here.
Okay.
Give me a 018.
I'll help Ajit set up. Yeah.
Yep, you set up Ajit. Ray, come on this side. Give me an 018.
PK,
yeah,
would you use a 4 balloon or 5 balloon and make a bigger track and try the Pioneer again?
I could. I mean, I think the other
We have
idea
an
is kind of very appealing to me right now.
Yeah, I mean, you have the device out anyways. I mean, now we just, it's not like we didn't try from below. I'm saying, at least you'll have to make that track anyways. Even if you have to stent, you still have to make a 5060 track for the super.
But hopefully, if we you're right.
Unless we cross in a different direction.
I know, but it doesn't matter which plane you go in. With that amount of calcium chunk, you still have to make the track. We already ballooned it. We might as well use this track.
Yeah, I mean, you know, like
So
I told you guys, this is a very challenging case. I mean, I think
So that be ready just in case, you know, if you need to.
Yep, I agree. Go ahead, Ajit. Yep, you got it.
Yep.
I'm out of your way now.
Thank you.
Okay, you got to bring the ultrasound machine
Can we
to
make
Dr. Rock.
the-
I'm on this side, right?
Yep. Can we bring the ultrasound closer?
Yeah, he's coming right now.
Or Ray?
Blanky, what's the name of the other crossing catheter with the needle on the tip?
Oh, Wingman.
Yeah. Wonder if PK, do you want to give that a shot from below? See
Yeah,
how
the
that
Wingman?
works. If you can.
But I don't think we have overnight. When we can use.
We have
overnight.
it.
No,
We have it.
we have
it?
both.
Okay.
We have both. Yeah.
Can you get is there any way we can change the monitors, get the accessory monitor out and the other one closer to him? Yeah. Perfect. And then this one, the ultrasound machine closer to him.
Yeah, perfect.
It's a very, very tough case, PK.
Well, you know, we figured with
that's good.
Srini, we got to give him something good.
Can you change the depth for him?
Oh, so
No,
I
no,
want.
I would
lighting?
stick antigrade. Sure.
Yeah, we're going, brother. We're going there. I agree.
No.
All right, give me a confianza, guys.
Than I am from below. That's tough. It's a tough case.
Well, it's tough. Well, you know, it's
Very
all the
tough.
decision making, right, Srini? That's
Right.
the whole idea.
Calcium.
I mean, we have it here. We have it here. Okay,
That's
we
the
keep it open.
calcium.
We're gonna need
You want
it
me to
anyway.
forward?
Yeah, I think
Just to make
I'm
you're
pretty
not in
sure
the-
as soon as you balloon below that level of
I
the
think I'm good.
collateral with the
see
5
the-
balloon, coronary balloon, you'll
I see
probably
the
make it.
calcium.
I hope so.
The
Yeah,
graph
you will.
comes from the
Yeah,
left.
that's the calcium.
Right.
So this would be good right
I
here.
feel
I
like,
think
you know,
that's a good
in these
idea.
kind of cases, card technique is like the best. It always works.
We're okay with
Yeah, I mean, I don't want to keep you guys too long, so I'm going to give another 15 minutes, and then we'll continue to work. We've got all the advice from Srini, as well as from Ajit. So I know Ajit's got cases, and we'll continue to
Yeah,
work.
I
We'll
think that's
continue to
good.
record,
Nice.
and we'll
soft
post
molecular
this
calcium.
online. Like currently, I'd like to at least cross for you guys, not you, but the
I'm
audience
going
at
to quickly
home.
get a fluoro PK
And
for
then
1
take,
second.
yeah, you can take fluoro.
Yeah.
There you go. There's the wire down. Yep, there it is.
Going
So-
nice and easy.
Yep, you come down here. Maybe you cross. Keep coming, brother.
Yeah, that's just
I
introducer.
would
let's
love
do
to
that.
see this wire just
The
cross by
introducer?
itself.
Fly through.
It may.
I mean, it may because you created such a big plane, right?
Which wire are we going to use, though?
Well, I would go with an 014 wire so
Oh,
you can
yeah.
steer it into my catheter if you can.
Okay.
Laura?
I guess we're doing the whole thing, right?
Yeah.
Yep, good.
Gonna
In.
put a
Is it
sheet
reaching?
down.
Fantastic.
All right.
No, yeah, it's there.
Is it there in the vessel? I hope
Should
it
be.
is.
Yeah, our micropuncture's in.
Yeah, definitely.
It's there? You sure in the
Acupuncture is in,
vessel?
yeah.
Okay,
Yeah.
I want to make
Yeah,
sure it's
yeah,
in the vessel. Okay. All right, cool. All right, show me down below. Let me see.
Yeah, it's
Yeah.
pulsed
Yep.
there. It's
Okay,
Pulse
there.
tau.
give him a wire now while I try from below. You can try from go to low mag here, Ray.
Here's a
What do you
needle.
like?
Give
You
him
want confianza?
uh,
Or you want-
give him a command. Let him try
Let's
with
try
the
command.
first, Laura.
We're a little sharp.
Yeah,
Oh,
honestly,
there,
if
that's fine.
I think considering the amount of devices we've taken from the
Come on,
single
you're right,
vessel runoff pedal here, I think if we manage to cross antigrade, I would actually prefer to take out the pedal axis and finish working from above. Just because of the fact of we've had this large outback to the AT,
I'll hold it
a
for you.
pioneer
You
through
shape
the
whatever you
AT.
like.
I'd rather preserve this single vessel.
No, the only question is you have to come back for that common femoral, or you're
Correct.
just completing the case. You want to just complete the case and just finish it off, in one setting instead of just re-accessing things and everything. You're there anyways. It's just one. It's just going to add 10 more minutes to your case.
Or lose a single axis.
Or,
Well, you know, guys,
you
listen.
won't.
Yeah,
Yeah,
you know,
it's a challenge.
you won't.
It's a
But
lot
look,
of difficult
every-
choices.
I mean, part of what we're doing, trying to
Yep.
show is
Right.
where we are in terms of our decision making of when we get pedal access. You know, this is a lady who doesn't really have much option. So, you know, when we do pedal access in
Can I
these
get a
kind of
what rate?
patients, I think it's reasonable. Okay, come down.
Can you
here.
get the other monitor for him as well?
Okay, there you are. Okay, I'm gonna pull Ray's gonna pull the
Uh-huh.
catheter back.
Can I get a torque on this?
Hold on.
Yeah.
Why don't you guys put an 018 wire from there? There you go. Let's see if I can find your plane here.
Uh-huh.
You can do a card here, maybe. Let's see.
Yeah,
Uh,
that's a good spot to do the cut.
let me give you a torquer.
So then the next question is, I assume we would finish therapy of this this segment of vessel before treating the CFA, right?
Yeah.
Oh
Yes,
yeah, definitely.
yeah, definitely.
At least
Yeah.
ballooning it, brother.
Yeah, yeah.
I think as you can see, it's not easy. I mean, I think he's going to need some support. I'm
Mhm.
gonna
Yeah, there's
have
no
Ray
support from the
just
top.
Yeah, I think
just pull it
Support
back
would
a
help.
little. See, it's he needs support up there.
So,
It's not going to
Yeah.
cross.
like a
Vishal,
018.
Yeah.
you
018
I think it's a-
quick cross.
you have a pedal access sheath or?
Yeah, we have a 4-5 slender. Actually, a 5-6 slender.
What do
The
you mean?
pedal access is fully sheeted.
No, I'm
with all
sorry.
these-
No, in
For
the
the
antigrade,
antigrade.
in
For
the
the
antigrade.
antigrade
No,
access.
antigrade, we just have the micropuncture sheet. That's what I was
Give me the
talking. We
Terumo
can take an
glide wire.
018 stiffer
018
support
wire.
wire if he doesn't want to put it in.
Yeah, we don't have to put a sheath in. We can just
Yeah.
bear back the
So-
018.
Correct. So give me a stiffer wire. Let's take a stiffer wire first, then exchange for an 018 now because whatever over it.
So here so while they get
Give me an 018
a
stiff
support
command.
catheter in from above, I'm just going to try with a glide type catheter from below and see what I can find. Because sometimes when there's a wire,
Or a Navic
Srini's Ajit
Whatever.
has created some planes, flush it.
We need an 018
Ajit has
stiff
created
command.
some planes, and it may
So
work.
that's what I'm gonna
Yeah, and it
exchange
gives you a
over.
good
So let me
target too to
see.
aim for. Would you ever
Extra
consider
support,
either bringing her back, like using a steerable sheath? Is that
What's
in
not-
your
I mean, that would
algorithm
be-
for this?
That would be the next step. I mean, but I'm afraid of that. That's the reason we tried not to do
Right.
it here. Let's see. I mean, let's see. Give a few more minutes, and then we'll keep working offline. I know we like to finish these cases, but this one doesn't look like it's amenable for an hour.
Yeah.
Flora,
So I'm gonna have to take this off now.
Yeah, I'm not sure.
Parker on this. Pull mine back, Ray. The catheter back.
Let's go up a little bit,
Let's
Ray,
go.
for a second.
Yeah,
Yeah, you guys go up.
Yeah.
You're on a little collateral.
I might need a torque on this.
Yeah, I'll give you a torque. Yeah, come
Gotta
back,
come
come
up
back.
higher.
I think we.
Yep,
Yeah,
right there.
no.
Nope. Yeah, there you go. There you go.
Yeah.
Another
That's
collateral.
Yeah, can I get a torque?
Yeah, sure.
Beautiful. Another collateral. There you go.
Perfect.
Nice.
Watch for the ultrasound. Take the ultrasound. Don't drop
Alright.
it. Okay, perfect. Now I'm going to give you. So you want to open it?
Looking
Yeah,
very
I'll take the
promising.
torque cross.
You have an Navicross open 8 open?
Track, right?
I got 035. Can we get a 018?
Even open.
Looks like I'm in. Hold on.
Yeah, PK has one. We need the other one.
Mhm.
I got it. Don't worry about it.
Same problem. It was really
Yeah.
What catheter are you guys using from above?
above.
gonna
You're just
switch-
gonna go with a regular Navicross, 018 Navicross,
Yeah.
I think, or
So we have a stiff wire down. We're going
or a
to Navicross.
you're doing Navicross.
Yeah.
Okay, he's doing Navicross.
It's just we have to cross the fat and
Mhm.
fascia, everything. So it's just better to go now.
This is 018 Navicross? Vishal?
Yeah.
Yep.
Pull back a little. Give me a Ashtato
No, we have
21.
the-
So
then you would
PK,
snare
just
from
for
the
the
bottom?
PK, just for the audience, or Srini, the card technique you guys do is you
Yes.
balloon from above, balloon from below, or and then re-enter into
I got
one
it,
of the
thanks,
segments.
I mean, I think in this case, I would put the balloon from below, right? Just
Can you pull the wire
because
back?
you got great access from above right now. It's a nice, looks like the wire alignment is pretty normal.
Mhm. Yeah, clean that
I don't
up.
think it really
Catheter going
matters.
down.
I don't think it matters in
Was
this
it kinky?
case, but I probably would go from below because maybe we get a better channel down below too, right?
Guys, I mean, there's no question you have to go from below with this access because I think Srini's just being very nice. I think the bottom line is, if, you know, if you put a sheath in that SFA and then you're working with that sheath, you're creating a whole different set of problems. I think here you're gonna have no problem in terms of getting the pedal sheath out without a problem. But I mean, from above, if you put a sheath, I think you're gonna have issues.
Hold on, let me give you a little bit of.
Oh, watch it, please.
Yeah, sorry. Hold on.
Is it going or no?
Just need a dry ray tech here.
Okay.
We're in the artery.
Oh, you're definitely in the arteries.
Yeah, it's just the way it kinks. Hold on, let me give you a little bit of support with the tissue. Ray, can you fix the?
Yeah, somebody just has to hold.
Yeah,
there it goes.
I am.
There we go.
There
Just
you
trying
go.
to
Flora.
give
Good
extra
job, Flora.
support. The fat, that's what I'm saying.
Excellent.
Yeah,
This is the problem with sheethless. It's very difficult. I
Yeah.
agree with you.
Yeah, I know,
about
but PK, why don't we
Dry
put
ray
like a
tech?
pedal axis sheath?
Yeah,
Yeah,
that.
kink.
Did you guys cross already? Looks like you crossed.
Looks like
we
you
done?
guys crossed, right?
Looks like it.
Yeah.
I don't know.
I don't know.
Yeah,
Push
we're
a little
close.
more. I think you're going to cross.
You want to try
Yeah,
advancing
you're going
wire?
to cross the ballooned area. Good.
Yeah, you
Come.
crossed.
Wait, hold on. I'm going to wait. Let Ray and I pull this back a little.
So much excitement.
So that's called the no look technique.
That's
It's just your
called
push.
the no-look technique.
You push,
Nah.
you push.
Now try.
We don't know.
But it went very easy though.
You know, you keep pushing and it'll go somewhere. So,
No, but I don't like. It's too much resistance.
Yeah, that looks like it might be.
yeah, I think you already made that
Yeah.
bend. I think you're in. You just have to get the catheter.
No,
You
no.
can push a
Remember,
little bit more.
Lose
No, no.
the loop here.
I know, but there's probably a kink up
You can
there.
push a little bit more, PK, Vishal. I think once you go through that bend, you lose the loop by yourself.
No. See, what I'm trying to say is there's a possible kink up there with the entry point.
In the wire.
Here.
Like what you mean? Like
See,
you're
right
talking about
where-
right at the axis?
1 second. Just stop for a second.
Here. Look. Yeah, I want to see. Okay.
Let's just see if we can get in here. Nope, it's not.
PK,
It
look
popped.
At it. Yeah, that's something.
PK, I think it popped in distally.
I hope so.
No, I'm saying you can
Just-
probably
yeah,
get
just-
into the catheter
yeah,
distally.
Right.
Let's
So just look at the calcium distally. You think it's just I can't transmit my force, and I don't want to.
There you go.
No, I don't like that. It's big loop.
It's going to pop right in. Okay, you're in. You're in.
It's in.
Now hold on. Now
It's in.
let's
It's in.
put-
It's in.
It's in. Don't
No.
push it.
I,
Hold on. Let's now. Can you track it down a bit or no?
It's gonna be a little hard because it's getting.
Now you
stuck
can
in
lose the
subfield.
loop, Vishal. If you pull it back,
no,
you
wait,
lose the loop.
No,
now.
you have to get
the
catheter
problem is
down
we
first.
can't. Hold on. I have
see
to
if it's
track
going.
my catheter down.
Not
You
necessarily.
look up top, guys.
Yeah,
There we
it
go.
is. No, that's what I'm saying. It's probably the issue
No,
we're having.
I got
Yeah.
the rail. Just come.
She just has a pannus, so it's
Correct.
a little bit
Keep coming.
kind of kinks the catheter.
coming, guys.
But
Let
it's
me-
coming slowly.
Let me hold it. Let me
Pull it
flatten
back
it here.
here.
So
Even a little lower would be nice.
Maybe just make a
You had
small
it
nick
lower a second
in the
ago.
skin.
no. It's just the
Open the track a little bit.
It's just the pannus and
yeah, just the pannus. But remember, at the same time, when we keep pushing, we don't want to kink the wire. Otherwise, we'll be like
Oh, yeah.
shot.
All right, we're almost there. Should we advance wire or keep going?
Hold on. Let me try to advance the wire here. Hold on.
Okay.
Laura Ray.
No.
We're definitely. That's a collateral probably.
It moves too.
All right. Then let's leave that there. Let me take my wire from below. See
Really?
what the floor.
Hold on. Wait. Ray, can you give me a torque on this? Oh, here it is.
I think you should change the wire now.
No,
Mhm.
wait, PK. I think we're right there. Ray, can I get a torque?
I think you guys should change that wire.
PK, you don't think the wire can get into your vessel? Are you not in the same plane, you think?
Yeah, see, we're right there. There it goes. I don't know how close you. You have to change the wire.
I know,
Vishal.
I know.
Get-
Okay, I'm changing the wire.
Yeah, get him a field of wire here, guys. He needs a wire that he can torque.
See, that's what I was talking about. See the nick,
Yeah.
the bend in the wire? And I could feel it that it's going to bend and then we're going to be having more trouble. Hold on. Let me throw
Are you getting
this.
blood
Pull
back?
your catheter back a little bit here. No, I'm on top.
No, you're on top.
Let's go to a different view, guys, while he gets everything ready. Watch your knees, Ajit.
Mm-hmm. You want to pull the catheter back?
Yeah,
or?
pull your catheter back a little bit.
I think you crossed, right? You crossed there.
Yeah, wait, Ajit.
No.
Don't pull anything. What is that? Here. Thank you.
Hey, you guys come from above.
Hold on.
Mhm.
Because they cross from above. If you take an 035 catheter from below, you're probably better off re-entering from below. I mean, getting into the catheter in the pop area.
That would be ideal, yeah.
Yeah. Let them
They
come
come.
because they look like they're really free there. So
I agree.
yeah.
Oh, totally agree. They should come. I was just trying from there, going to Flora.
Oh,
No,
look at that.
that's you know, so that's
Oh wow.
Vishal had breakfast.
We wanted to give you a 3D imaging of how cardiac. I mean,
That looks different than before, though.
yeah, that's what I'm saying. Hold on. Ray, can you give me a little bit torquer, please? Oh, see, that's why. That means we are in different planes.
Yeah, wait, leave it there. Touch. Did we touch? No,
no,
right?
no.
Yeah, I touched you. No, you're right. That's you. Well, that's the key, guys.
This one.
So is the plan now your 035 Navicross from below? What are you
Yeah,
thinking?
we're just gonna now just see whether you can Ray, push my catheter up.
I think
It
from
seems like
above
it's
it's
in.
looking
You're
better.
good
It's in,
right
right?
there.
So yeah,
Hold on,
enter it
hold on.
there. Yeah, get into
Hold
the
on,
catheter
one
there.
second. Can I sit down?
You're in the catheter or no? Get in the
No.
catheter. You got to put it in the catheter, Vishal.
1 second.
You crossed the catheter, dude.
Okay,
What are you doing?
I am. No,
Get in
No, the catheter is down there, PK.
catheter
Yeah.
down there, PK.
Catheter is in the AT.
Hold on a second. Let me get the catheter. We ballooned this. Please
Yes,
do not cross.
I'm
this.
not.
Give me a what is it called? A command wire.
You know, usually
Pushing
we're always
through a
talking
loop
about
in an area that was already ballooned. What are
No,
you
but
doing?
you told me catheter is down
Yeah,
there.
but I'm saying you don't push through the loop.
It's
So
real
you know, it's
there.
why we're arguing here is that you cannot
Yes.
push through a loop in an area that's already been ballooned. So that's something you don't do. So I think what we need to do is get this catheter up elegantly. We've definitely crossed from above, and now we need to elegantly go ahead, get this catheter, and then go ahead and wire into it. Pushing with a loop is, and if you create a flap from above, then you're in trouble again. So we just need to be very, very gentle in these kind of cases. I know everybody's excited about crossing, but the idea here would be to now finish the case.
PK, maybe this would be a good point
Can you
actually
hold
to
this
talk
towards
about a few tips and tricks on how to re-enter
Flora.
into another axis catheter to avoid having to use snaring devices.
Can I see, guys?
Yeah.
I think where's my catheter? Oh, there you go.
The catheter is
So-
in the proximal AT.
Yeah, we see it now. Why is it coming back? Can somebody put pressure on it, please?
Yeah, right. I got it.
Thank you.
So do you
One
prefer?
other thing you really want to be careful is, see, when you might have a dissection plane here, which you already do, which the question is, was the loop of the wire that caused this dissection? See, that's what I'm worried about. See, this is all, you know, you've done so much work here. Now if you end up with a dissection here, now you're in trouble. There you go. Okay, now Ray, track it up. So we're gonna have to stent this. Track up the catheter, please.
Yeah, I'm coming.
So it's the same thing. Like, I don't know if you guys saw the subclavian case last month. A little higher. Okay, a little higher, please. Further up into the mid to tibial tuberosity. It's the same thing. We track the sheet
That's
now.
good.
Now you try to wire it. So I think that the same kind of thing when you track a catheter through a balloon segment, you're always going to get in trouble. You got to be very, very careful in those kind of things. You have a wire in front and then do it just like with a loop here. So coming from below, even if Vishal had created a dissection plane from above, that's a different story because remember, coming from, there you go. How about there, Vishal? That angle might be more favorable for you. I think that is the significance come from below versus above.
PK, Vishal, I don't think Vishal has the capability to torque. PK, I
have
think you
no
might have to take a
capability.
deflectable. You might have to take a deflectable Navicross 035 from below, and you might have to
See,
wire into it. Yeah,
Maybe, yeah.
yeah. Because I think he's not able to torque because
Or
of the pannus.
why don't we do Kumar's favorite thing? Let's take a micro snare. Let's take a micro snare, and then pull it into this
That's it, Vishal. You got it. Almost.
right there. A little lower. Want me to pull the catheter back, Vishal, or
No, I don't like it because you're right.
or we can give you an angle. This is an
That's
018.
it.
I
If
can,
you
I
straighten
can,
up, it might fall in.
you know
Yeah,
what?
ma-
Give us a 035 Navicross. Let me do that. That may be
I'd
easier.
probably use,
Yeah.
035
Give us
Navic.
03.
Yeah,
I'm walking this out.
He's having so much difficulty torquing it. So.
No, also maybe also doing it in the straight segment of the AT.
There's a
make
loop on the
things-
top. What is
I
that?
know.
Yeah,
that's
that's
why.
just in the collateral.
Oh, okay.
Yeah. Maybe also going from the straight segment of the AT, not having to worry about so many angulations.
But you don't want to take
from
the
below.
catheter across the balloon, the wire across the balloon segment. Can I have the 035 nav across, guys? So right now, I think we can easily wire from here. Or we can take an Aqua Tempo if you want, or a JR4. Any one of those catheters we can go through.
Angle nav across is good, smooth. I think it'll track it'll also track the plane better.
There we go. Ready? Real? Okay, good. Let's go.
Are you just worried the snares may not track?
I'm just worried about the fact that if we snare it, we're gonna have to pull it back into the sheath.
If you lose the snare,
now you gotta watch the loop. Yep, go. A little higher. A little higher with the. There you go. Now you got it. Now you can just pop it in. Let me torque this catheter away. Srini said here. There you go. Now try. There you go. Nice job.
Nice.
All right. So he's going to just push it out if he can. I hope he can. As he push.
PK, can you push your catheter
I'm
over
far
this
away.
wire?
Yep, I'm far away, but I think Vishal's going to be able to push it out. We'll just push the catheter over this wire.
Hold on, wait.
Yeah, it's fine. It'll track. It's a plane. So.
I think it's better.
Remember,
if
I have an angle from the top.
Okay, let's try to push the catheter up.
I don't want to kink my.
Okay, don't
it's
kink it,
coming.
Vishal. Let's just push the catheter up from
Is that better?
below.
Now
Yeah,
it's coming.
leave the
Yeah, it's much
catheter
better.
there, Vishal.
Actually, no, it's almost out. Vishal's doing a great job. Show me down. Oops. Watch your knees, guys.
Yeah.
All right, there it is, Vishal.
PK was trying to make it tough on Vishal with the 018 catheter.
Yeah, I see that. I'm just somebody
Thank
has
you,
to.
Srini. We need an independent.
Independent assessment.
Somebody in the team has to vouch for Vishal. So I was trying to make it easy for him.
You'll have like an 018 wire from above, a 14 catheter from below.
PK,
Wire it in.
PK is always harder.
Now let's pull this out. All right, ready? All right. Okay,
beautiful.
we're through and through now. So now,
Srini, once in a while, I think we need to have moderators from outside
you can lose
to know
that,
how
the
hard
catheter
our
from
boss is
above.
on us.
Okay, pulling the
Hold on,
catheter out.
give me a
Climb
forceps.
mosquito.
So what we're going to do is now we have Safari. Now we're going to just get us a. Oh, do we have Sterling balloon, guys, or no?
All right, I'm going to pull the
Yeah,
catheter.
pull that catheter out.
So now we talked about that. What's the plan now?
Now
We're
feed
gonna
that
Hold
to me.
pressure. Let me hold pressure.
Now feed it to me. Feed it to me, guys. Yeah, once
yeah.
we.
I don't know if you can.
Okay.
Yeah, here it comes.
You have to.
Yep. Feeding.
I'm pulling.
Feeding.
All right, get us the Shockwave. Set it up.
1 second. Let me just get rid of
Shockwave
this catheter.
6.0.
Yeah, I just don't want it to.
Is it coming or no?
Yeah, I just got to get rid of this
Yeah, I just
catheter.
want to make sure it's not kinked and bleeding at the same time. So I just have to be.
Okay, advancing wire.
Okay.
There you go. Perfect. All right, now we're going to load the Shockwave on here. Now we have through and through.
When you cross over,
mosquito.
we don't care.
Say again?
Yeah, with the sheet.
So this is a really tough case. You
Actually,
guys made
before
it-
that, okay, can you
I
give
got
me
pressure. I got pressure.
a 5015 Viatrack?
Wow.
So what I'm going to do now,
We
Srini,
gave you. Would you
We don't
want?
do the other way around. Yeah, I want to put a micro catheter, swap your sides of the catheter so you can work all the way this way.
no, what I'm
do a
going to do
wire
is
trunk.
internalize the wire and then push it up into the common femoral. So,
Yeah.
so that's what we should do.
That's
Yeah,
what it
but
is, yeah.
I want to balloon the track so that we don't get into any trouble.
Sure. Okay.
So,
So-
give me so what I'm going to do here is just balloon my reconstitution zone. So this way, then I can do what Vishal was saying: put a microcatheter up and then flip it all the way through and through. Right now, because we have through and through access, and we have what's called as a what is it called, Safari. There's really, if Ajit holds, if Ajit is taut and I'm taut, there's really nothing we can't get through this.
Right.
So you don't want to give up that through and through access first. So it's good if I can push the Shockwave up across, balloon it, and then establish flow. And once I establish flow, I think we can go ahead and then do what Vishal said, put a microcatheter in, Shockwave the distal, and then do this. So what I want to do is just do one Shockwave and then exchange the wire, and then we will be leaving you. I know Srini's got cases. Thank you, Srini. I really appreciate you staying a little bit over time, and then do it. So Ray's working his magic here, getting the wire in, because I made it difficult like I did on Vishal, putting it on the soft part of the wire. But I just got to tell you that nobody, that you know, the whole aspect of this is the thought process of all of us together trying to, you know, solve this problem, you know, and it was amazing, you know, getting the antegrade access with just a sheetless, and then doing one by one these things, and I think it's going to work out where we're going to end up with a reasonable result. So let's go now. We're just going to try to shockwave. Srini, Vishal is going to hold. We're going to hold taut here, and Ajit is going to hold taut up there.
Okay, what are we shockwaving? The pop and the distal SFA?
I think right now just start with the pop and distal SFA, and then internalize the wire. Okay. Put the wire up into the common femoral, and then go ahead and.
But you don't think the catheter can go across the wire now?
I just, you know, you never know, right? So, I mean, to me, let's create a plane. We have through and through access. I don't want to give that up yet.
How far do you want to go up?
Give it a die from above, guys. This is the 5015, right?
Wire track.
Wire track. All right, ready? Go ahead, balloon this area. Okay. So we know that they were luminal till the occlusion point. So I think this is the area which now is going to help you a lot. Just some quick balloons in this area. 10 down. So this is an 014 renal balloon for those of you who don't know. It's a great balloon for the renals. It's a peripheral balloon, comes 5, 6, and 7. And it's something that I think everybody should have on their shelf for these kind of cases. And now we're just going to balloon this open. And you see how it's watermelon seeding out. I think it's come down a little lower. Get shockwave ready, guys? Okay.
Nice.
10. Down. All right. So, Srini, what do you think shockwave is going to add to this, Srini?
Well, I mean,
considering how this balloon is inflating, yeah.
I think if we drink the shockwave Kool-Aid, as they say, it should get microfractures.
That's where the problem will go up and down.
Right?
That's
soften it.
We're going to do shockwave anyway.
Yeah, I didn't want it to go through. Okay.
Come down now.
So I think it'll help a little bit.
A little more, Meg.
That's good.
Yeah, go up there. Yeah, so I think that's why we're going to do it. I mean, that's well expanded down. I think you're right. There are certain spots that have a lot of calcium, right? Oh, that spot right there. Yep. That's the spot. A little higher.
Sorry, I couldn't see.
Higher.
I mean, I think like Raman said, part of the problem is that, you know, we're dealing with really extensive calcification in that popliteal artery. So, you know, how much
yeah.
10.
benefit are we going to get? Hopefully,
all right. Now we're going to go with the shockwave. So we're going to go quickly with the shockwave.
Yeah.
And we got a 6060.
You know, Srini, I don't know if you observed, the inflation now was a little more less eccentric than the first inflation, right? I think this plane is so much better than the previous plane we have because the eccentricity was much less in this plane. So
yeah,
I think shockwave might help now.
Yeah.
This is over the wire, right? No, it's monorail.
Would you primarily? Sorry, go ahead.
Or the wire is in more of an AP plane, right? You're subintimal,
Right.
but you're in an AP plane. So we're not seeing it. It's not it's not accentuated much, right? That could be the possibility too.
So now we're going to go over the wire here, which is going to allow us to exchange the wires as soon as we cross this and do a couple of shock waves. So the wire is not going to be there. We're just going to keep the system straight.
Do you have the wire?
No wire.
System
We
straight.
don't have the wire.
Yeah.
No wire.
Straight.
Yeah. System straight. Yeah.
It's okay. It'll come up.
You got to walk with me, guys.
Welcome. Just keep walking. Yeah.
Would you all primarily stent here or DCB and spot stent, or what do you think?
I think I would primarily stand here.
You still don't have the
Wires out?
Yeah, go on.
Okay.
I think we're going to have to.
Yeah, so now you can see even with the 5.0, look at the struggle. Even with the 5.0, guys. Wow. Rail, pull the wire, guys, both of you?
Rail.
Really pull the wire hard?
He has the wire on the other end, so don't worry about it. It's just pull.
Pulling here, yeah.
Wow. See, this is why, Karthik, I didn't want to lose. You see? I think we should go up here. Let's go up. This is why I didn't want to lose the through and through wire, brother.
Yeah.
Go forward. Go up.
So even with the through and through wire, we can't get this up.
Yeah.
Okay,
Forward.
go.
Good.
That's quite impressive.
Yeah, stored it.
This angle, I mean, the alignment looks so much better though, like Karthik and Raman. Like guys, I mean, really just incredible. It's just you've got this eccentric calcification, even though we're subintimal probably. It's tough to.
One more, of course.
Some people have
Six.
done laser
Six.
here.
Down to
I know
4.
Jay Matthews talks about lasering even when he's in the subintimal plane. I've never done that.
I don't know, Srini. I don't
4.
think laser in my hands.
back
I
to
don't know,
4.
Ajit, what your
Do one
thoughts
more.
are. Does laser work on calcium for you guys?
No, that's
No,
what I'm saying.
definitely not.
Yeah.
I have never
I
had
haven't.
received success
I
with
don't think
laser
that
and
works.
calcium, PK.
Yeah, I've only used it a few times to be honest, but it hasn't really helped
Yeah,
with
you know why?
calcium.
Because the coronary guys, including myself and Vishal and Raman, we use it in calcium in the coronaries and Karthik.
No.
And to me, I've never been impressed with the results in calcium, but SS, our director of our lab
6.
in interventional cardiology,
Hold on.
swears by it. Obviously, Rhoda is number one there, but Flora? Oh,
No,
I'm sorry.
but sometimes what happens is when you have a focal lesion,
Rail
you have
guys,
to
pull the
break
wire,
through the,
guys. Pull it hard.
Hold on, let me
Yeah.
put on the mosquito. Wait,
It has a much more
Correct.
well-defined niche
Exactly.
in the coronary realm for the uncrossable lesion where you can't get your delivery device, your wire,
Exactly.
whatever you need across.
So when you have a
you know.
right non-dilatable
Okay,
focal
let's go up here
lesion,
now.
you can actually do a laser blast it
Yeah.
to create a lumen, and then you're right, take smaller
Yeah.
caliber balloons, and then you
Yeah.
crank it.
As a primary atherectomy device, I don't think I have had any success. But when I couldn't cross again, take a smaller laser device, blast it, and then upgrade it to, a
Correct.
rota or something. It helps.
Yeah,
But I've never primarily had a success in calcium and laser.
6.
6.
They apparently
agreed.
it took off 100 pounds from the tank, right? And now
Yeah.
so now it's 100 pounds less. Now it's just 600 pounds.
And it's a rolling device.
Ajit tells me he goes to the OR on Saturdays to work out with the laser machine.
Yeah, I wheel it up and down the hospital.
He told
Thanks so
me
much.
he doesn't have to pay for gym membership.
No,
Just wheel
it's,
the laser machine.
it's like Karthik and Srini's
rail guys.
Tesla. You have to charge it first before it works.
Exactly.
What's your
Rail guns?
I
atherectomy
have
of
them.
choice for
Pull
calcium
hard.
then?
I am.
Do you have like a device that you
Pull
prefer
hard
in
and
it?
hold that thing.
One second.
Calcium, that's a great point. Pull hard, guys.
I
It's
have
not going.
mosquito on
There
it.
it goes. Come on, a little
I think
bit more.
calcium. It also depends if you want to stratify it, right? Are you dealing with mild calcium,
Okay, let's go up
moderate
here.
calcium,
Yeah.
severe calcium?
Yeah.
Because
And then
that's
also
what
whether you're
calcium.
whether you're luminal or subintimal, it definitely changes the your algorithm here.
After doing a lot of these for over now 20 years, I can tell you that severe calcium, my answer is Dr. Rao. Dr. Rao will do an endarterectomy and we'll do a nice bypass and we'll get a patency rate of 5 year of 90%. I'm happy with that.
Yeah, that's true.
It's true,
Scalpel
man.
still
We
works.
do
Yeah.
all this stuff and it does. So like this is a lady
One
who
more
doesn't
time,
have an
yeah.
option. You got to do it again. Let's go to 8
Yeah,
here.
we did.
So we got to really expand this.
We
So the
did.
question is, do you think you're
Six,
interluminant there and can we change the wire
keep it at
now?
6.
I think we can.
No, I would probably go until 15 or something and then change.
No,
the
my
wire.
wire is all trash. So if you've crossed it, I would like to change the wire on this.
Yep.
Otherwise, we'll.
We have to pull
We
it out
want-
this way.
Yeah, exactly.
Yeah,
But
just
what I'm
probably
trying
go
to
up
say
to like 15 or something and then take it out.
Well, it's very hard to push, brother. I'm telling
is-
you.
it is. Trust me.
Yeah,
And the soft
okay.
end of the wire is.
Yep.
I'm just
All
scared.
right, down. Now let's take a DSA from above just to see where we are. Okay, DSA, inject.
Yeah.
We'll go until at least until 20.
I agree with
Yeah, I
you,
would have to
Karthik,
go
because
push a
there are
little bit
planes
more.
from below. I do agree with you. There are planes from below. All right, good. Yeah, we got to go up more.
See, it's
I
still
agree
at
with
17.
Karthik. We got to go up to at least 15.
At least
All right,
15.
all right, one more, Flora. Let me see if this goes up.
Yeah, just pull both
What?
sides of the wire and then push, I guess. Yeah. I know it's not easy, but easy to say sitting here, but
No, we have the best seats right now. These are the best.
I know, right?
Yeah.
Okay, go up here.
We can change the.
I don't
focus
want to be in that room.
Alright, go.
Vishal has to give surgery to that wrist. More or so.
Oh my God.
So PK, what's your next step here after this? You're going to balloon to 6. What size supera? How are you going to size this?
Well,
Are you gonna hide
what I'm concerned about now, Srini, is that we have through and through access and are having so much trouble pushing the shockwave up. So now the question becomes is how are we going to deal with that common femoral? So
Yeah.
obviously get a new shockwave
Eight.
balloon, and then try to get the shockwave
Back
up.
to 6.
I just don't think it's going to go.
PK,
If I put a stent
one.
here, Srini, the problem is going to become, okay, well, God forbid the shockwave, will it track up through the stent? I don't know. ¿Qué pasa, mama? Okay? Duele, she's having pain.
PK, you're going to exchange it to a steel core wire, like to get more stiffness?
Might,
Yeah.
we might. I mean, down. Okay. All right, let's walk. I think we should walk this out, go with another catheter, and then change the wire, and then try with a new
I
balloon.
think you're there anyways, right? You're there.
She's having pain when I push, so we're going to leave the wire as is, and I'm just going to track the shockwave out. You got the wire, Srini?
Yep.
Ajit?
Yep.
Okay, Flora? Okay, here it comes.
If you have more, just probably shockwave it again there.
Yeah, finish.
Finish the whole.
Yeah, I just want to get it out of her body. She's having a lot of pain. Okay, so now give me a 018
035.
Navicross?
no, a Navicross, yes, exactly. 035 Navicross, actually.
035, yeah.
Yep, it'll be easier. So now we're going to just take, let's take a DSA while we're here, guys. Let me see the thing. Careful, we got Jit. So the worry here is rupture, as we all talked.
My question was that rupture right at that popliteal area. It was like.
I think we're okay.
Look at the amount of recoil.
Obviously, a lot of recoil, so we're going to have to really
And
balloon this
dissection
open.
right there,
So what I may do now is put an 035 wire up and take an 035 balloon. And then, oh boy, so we're going to have to
That's
cut
what I'm
this
saying.
way. Yeah, we're going to have to cut it
Yeah.
here.
It's trash.
You have to cut it all the way here. So we're dealing with wire issues now, as you can imagine. Cut it right at the black point.
Yeah.
Mm-hmm.
Okay. All right.
I'm not cutting.
Ah.
No. You gotta cut. You gotta cut higher because otherwise you're gonna bend it. You can't put it in. Okay. Get a couple of force of you.
I think you could probably get away with a relatively short stent, right? Most of it
Looks
looks like
like
it
it.
opened up.
But we also haven't seen that popliteal lesion as well.
Yeah, you can see a lot of dissection next to the
There's no question.
calcified segment.
No question. We have to stent this.
Yeah.
No.
Okay.
Okay. Just keep the system straight,
Yeah.
boys.
Yeah.
Show me down, Michelle.
Yeah. Great. Yeah, thanks.
Wow.
Thank God.
You got it or no?
Not yet.
Not
Not
yet.
yet. Not yet. Not yet. Wow.
Yeah,
No
right
wire
there,
yet.
right there, right there, right there.
No, but to get my wire, I still don't have my wire.
Okay. Well, you can pull
Oh,
out
it's
the
okay.
wire
You
now.
can pull out the wire.
You
yeah.
pull out the wire.
I'm
Jim.
pulling it up from above?
Yep. I
Okay.
think so, right? You were
Yeah,
right
we're
there.
Yeah,
still-
we're
okay.
definitely
Yeah.
crossed.
Okay. Let's take a. You want to know
Spartacore now.
Spartacore. Perfect.
Now let's save that. So we're going to put a Spartacore up into the common femoral. And the question here for Ajit is, should we put it into the graft or does it matter?
I will put it into the graft.
Graft. Yeah.
Okay. So
Because that's where the inflow is. You know,
Yeah.
the
And
actual
then when
native
you
vessel
use the
doesn't matter.
shockwave, yeah, the tip of the shockwave is definitely going to project a little bit into the graft.
okay.
You might want to.
So again, since we ballooned it, now we have got flow. I wanna sign off, and I know Srini's got work. So and so does Ajit. So the question is, let's just tell the audience the plan. We are now going to place this inside the graft if we can, right? That's the lesion of the. Oh boy, they're not crossing. Nice. Next problem. Oh my
Puff
goodness.
again, puff again, and see.
All right, let me go over here. Hold on, let me give him a roadmap. You ready?
Yeah.
Oh my God! Yeah, it's an
Is
occlusion.
there? I don't know.
All right, let's go.
No.
There you go.
Nice.
Yeah, perfect.
Got into the graft.
I was redirecting the
Oh,
water.
good.
There you go.
Okay.
Nice.
Okay, so now, Ajit,
Yeah.
let's see, we're in the graft. Are we in the graft?
Yeah, we're in
Yeah,
the graft.
looks
we're in
like
the
it.
Yeah, push it up.
Yeah.
Yeah,
Yeah.
we're in the graft. Now you're okay. That's enough. So now we're all the way here. So now, what do you guys want to do? So let's walk this out, Baya.
One more
let me
shockwave
take a photo.
of the CFA.
Another
I mean, I think
shockwave.
we.
Fix the sheet.
Yep,
yeah,
it's
one more
fixed.
shockwave of the CFA.
Yeah, shockwave and then stent distal and then.
All right, get us a new
Yeah.
shockwave.
6-0.
They want to go
Yeah,
with
no,
the
forget about that.
Vitrac for that CFA
Yeah,
first
6-0. We have to take a
to
6-0
open it up
shockwave.
to allow the passage.
Well,
of the
remember
I think
the
it'll go.
035 catheter cross, Roman.
Yeah,
So it may go.
Yeah.
I
Yeah,
think
it'll
it'll
go.
go.
You know?
I think it's more of a bend in the wire and everything.
So
Give us
this
the-
is the real $1 million question: is the popliteal. How far and how much? See.
No perf. At least we know that.
A little bit
All
of
right.
a plane. That's okay.
Yeah. I mean, okay.
So now I guess the discussion is going to be what's what. You want to stent this first, Srini? What are your thoughts, Ajit?
No.
I would stent the whole thing at this
Would you
point.
stent it first before you shockwave or after?
Oh no, I
no,
would
no.
shockwave.
Shockwave
The
top,
distal part,
and
yeah,
then
whatever
the-
we didn't do before,
And then a Dorado.
and then just
okay.
yeah,
Yeah.
for sure.
Yeah, I would
Shock-
shockwave first and stent
All
at
right,
the end.
So what
Because you don't want your stent not to expand, and then you can't track
Totally agree.
anything, and
nothing.
Yeah.
end up in a bad situation.
That's a 6, yeah.
Yep, 100%.
That's a
Yep.
5. You have to get.
All
it
right,
on.
let's just shockwave the common femoral.
So what we do is shockwave. You DCB the common femoral, and then you do whatever distal.
So this is a good question. Srini and Ajit, does DCB provide any added value in the common femoral?
I mean, I think so. I think there's definitely some data that supports it. So I would think shockwave and a DCB would be a good option if it expands well.
That's it.
Okay. Srini, any thoughts?
Yeah, no, I would definitely shockwave and DCB and try not to scaffold it if you can. I mean, I know there's a RCT that's taking place now with but ideally, if we can try not to stent that area across the joint, it would be ideal. And I think DCB works here too.
Yeah,
You're railing me? Can we attach
I think
it?
that would be
Attach
the
it now.
best option.
I think we attach it.
I think we can all
No, we
agree.
can add it anytime we want.
IVL for the calcium and DCB without scaffolding, I think would be
Real,
ideal
real.
for her. And for
Guys,
her,
I
we're
mean,
not
I'm
again, we're not
pushing it
we're not
up, so
going for
walk.
perfection here. We just
Yeah.
want this vessel to be a little bit
That's
more
fine.
open
Can you
than
just
it currently
take the
is.
machine? No, I have the one.
You got
And especially having a stent here would add an extra layer
An
of
extra level of
complexity if
yeah,
she ever needed
exactly.
surgery.
Exactly.
Getting stuck here.
Hold on, let me give him real.
This is what I told you. The through and through is so important.
Wow. Okay. 1 down, 2 more to go.
I think it should go now. I hope I'm praying. If not, we can balloon this segment again. Oh. We didn't even
Thankfully,
get
you
up
have that rail. I mean, that's,
No, we gave up the rail now.
We gave up the rail, yeah.
Yeah. Not going, boys.
Might have to
Shockwave. Let's go.
shockwave distal
Yep.
first.
1 second. Let's prep. This is 50-50?
50-50, yeah.
All right. So I guess we'll sign. Should we sign off? It's an hour and a half, Srini. I don't want to hold you. So thank you. I want to thank you on being our guest moderator here. Obviously, your thoughts and your suggestions are so appreciated, not only by us but by the audience. So thank you very much, man. I really, really appreciate it. And
Thank you, guys.
4.
so you can sign off. And again, any comments that come through, I
Damon,
will
can
let you
start?
know, and we'll take it from there.
Hold on.
All right. So
Thank you, guys. Appreciate it. I was honored to be part of this.
Okay, press on.
thank you,
Thank you,
Dr.
man.
Mullah.
Thank you.
Appreciate
Thanks a
it.
lot.
Thank you so much for coming in. Again, so we're going to wrap this case. Thank you, Dr. Krishnan, Dr. Kapoor, Dr. Rao, for an exciting case. I think there's a lot of points I think this case added. And I think it's the first time we have done something like this from pedal. So I think it's an interesting case.
So
we're
Karthik,
gonna-
what we're going to do, I just want to tell everybody, I think me and Ajit and Vishal are going to try to get this to the common femoral, fix it. Once we fix it in the common femoral,
1 second. Let it go. Flip.
hopefully,
Flow.
this thing goes. Pull it back so I can get some speed, and then we'll go forward. Wow, look at that. And then if we can do it in one setting, we will. If not, I think we might have to try to come up and over the next time and do it there. That's not going.
Agree.
So we can
So
do
that's
scoring
the
balloon
idea.
and then just do DCB.
I mean, okay, we'll walk this out.
You
So
want
thank you again. Huh?
Thank
We'll
you.
hit it on the way out,
So
exactly.
we're going to wrap up this case. I
I'm done.
think Dr. Krishnan is going to show the results, final results of this case, which I'm hopefully is
Right
going to
here.
be beautiful results. So thank you so much, everybody, for joining us. I think we're going to see you guys again on February 22nd for our next live case date, 8 a.m., same time. Me and Dr. Sharma will be here to greet you again. Thank you so much for joining us. Have a great
Thank
day.
you very much.